now. Sorry, I didn't realize I'd muted myself. Hello to everybody that has just joined. We're just going to make a start in the next minute or so. So hope you all are excited, and thank you for coming on your Monday evenings. I think that's a testament to everyone's interest in this topic, and we're in store for a really exciting webinar this evening. So we'll just give it a minute and we'll start at 2:00. Right, hello everyone. We're just going to make a start now. Hopefully you can all hear me okay. Thank you all so much for tuning in on your Monday evening to this MDT webinar on ENT, so ear, nose and throat. And today's webinar will be focusing on hearing loss. So just a few reminders, if this is your first time attending a Future Frontline webinar, then welcome. My name's Nikki and I'm the co-founder of Future Frontline. Just some reminders, whether you've been here before or it's your first time, please make sure if you're not a speaker that you keep your microphone on mute and your camera off. If you have any questions, please do save them for the end of the webinar, and where you can type them into the chat and the speakers will answer them. And make sure at the end we'll be sharing the link and QR code to our feedback form, so make sure you complete that for you to get your certificate at the end to say that you've come along today. And just a reminder that no information shared during these webinars should be used as a resource, guideline or reference for clinical practice or decision making, or by patients looking for information and advice. This is just an educational tool for current healthcare students, those interested in healthcare. So yeah, that's the purpose of these webinars. Right, so I mentioned quickly that this is a Future Frontline webinar. So if you've not heard of Future Frontline before, we're a community interest company. Like today, this webinar is free. Everything we do is free and it will always be that way. We launched in August 2020 and our whole mission is about inspiring and supporting people into a career in the NHS. And we're strong believers that interprofessional education, or IPE, is the key to collaborative practice and delivering the best patient care. So that's why all of our webinars are centered on cases are centered around the MDT. So a team approach, as it's only when we all come together that we can deliver the best care for patients. If you're active on social media, make sure that you take some pictures during today's webinar and share them using the hashtag FutureFrontlineMDT so we can see what you guys are all getting up to and how you're finding the webinars. A reminder as well, if you haven't before, we have a website where we have a whole host of written content for you to explore the MDT further, read up on hot topics in the NHS at the moment as well, and that's at www.futurefrontline.co.uk. And here you can see just the whole breadth of sort of careers within the NHS we cover. And even if you're particularly interested in one field, there's so much value to be had in learning the roles of different people. So make sure you do go ahead there after this webinar this evening. And here's all our socials as well, so you can follow us after. We have lots of interesting, amazing speakers who've given up their time to come and speak for us today, who will all be introducing themselves as we go along. But I'm just quickly going to hand over to our patron, Joe, to give a little bit of information on how he became involved as a patron and why Future Frontline is important. So over to you.
Thanks, Nikki. Yeah, just a few words, really. When Nikki and Tash and the team set up Future Frontline, they asked me to be patron, and amongst the other many requests of that sort of kind that come through, this really stood out as something that was, yeah, really valuable, worthwhile, and I just want to commend everyone that's involved for making it happen. As you get further and further into NHS work, you realise just what a juggernaut it is, and just what an amazing team that relies on every different field to actually make it run. I think, you know, if I look back to my med school years, I probably had a very, very basic understanding of what other fields outside medicine and nursing do. You can probably hear my wife, who's a speech therapist, in the background with our kids. So I have a better idea now. And obviously my colleagues are part of this as well. What I'd say to you all is that whatever field you're in, the more you can understand and work with and value the different fields within the MDT, the better you will be at your job. That is just, it's just such an obvious piece of advice, but probably one that we don't get taught enough. So for Future Frontline to be joining everyone from different fields at an early stage, at student level, is just, such a great idea. And so, yeah, good luck to you all. I'll hand it back.
Right, thank you so much. So we're going to start with our case then. So just to introduce you all to the case, this is about Nina, who's a 9-month-old baby. Her mother has brought her to the GP as she's concerned about Nina's hearing. She reports that Nina doesn't seem startled by loud noises, doesn't babble or attempt to speak. And as we've said before, she's 9 months old. Her mother's brought her to the GP. And so what would you like to know? So answer in the chat, what are key things? If this was a patient that you were, you were on placement as a student and you saw this patient, what would you want to know? What else would you like to ask the mother? So type your answers in the chat. We're having loads of engagement in the chat. Millie, do you want to have the honours of going through everything in the chat?
Yeah, so we've got all sorts here. So we've got family history of hearing loss. That's excellent. Medical history. Has this been going on since birth, or is it sudden? Lots of discussions about birth complications as well. Family history of deafness. These are all really great, guys. Keep them coming in. People have discussed how long has this been going on for? Any more? Infections potentially as well.
Amazing answers, everyone. We'll be touching on all of this and more over the next hour or so. So that being said, I'm going to be quiet now and hand over to the amazing team. And we'll be starting with medicine. So over to the medicine team to talk about your role in this case.
Yeah, so hi guys, I'm Millie and I'm a medical student. So I'm going to be starting off for the medicine team today. And actually someone has actually just mentioned in the chat newborn hearing screening. So to give you a little bit of background about what newborn hearing screening is, in every 1,000 newborn babies, 1 to 2 tend to be born with permanent hearing loss in either one or both ears. And for those who have spent more than 48 hours in intensive care, that probability can increase to 1%. With many patients having had no family history of hearing loss, and of course, due to the risk of permanent hearing loss, which can affect their development later on in life, it's understandable why early hearing screening is so important. So learning about this hearing loss as early as possible can ensure the babies can have the best chance of developing normal communication, speech, and language skills. So newborn hearing screening and testing is offered to all babies before discharge, or alternatively, a healthcare professional, assistant, or a visitor will perform the test a few weeks after birth. The baby can be tested up to 3 months of age, but it's ideal to have it as early as possible. So the main test that is performed, the one that's performed first, is the automated otoacoustic emission, AOAE test. And what this involves is a small soft-tipped earpiece placed in the baby's ear to play quiet clicking sounds for a few minutes. And so any unsettled babies or those who have fluid or temporary blockages, they might not have very clear responses, and so they can sometimes offer a second test. So they might offer the same test that had been performed previously, or another test called the Automated Auditory Brainstem Response, AABR test, is performed. And this involves placing 3 sensors on the neck and head of the baby, while soft headphones are placed over the ears to play these clicking sounds. And that one is slightly longer than the first test. That can be up to 15 minutes potentially. So as soon as this test is completed, the results can be provided to the parents, and clear responses in both ears suggest that it's unlikely that the baby will have permanent hearing loss. But hearing loss can be developed over time, so it is still important that the parents understand that they should be monitoring their baby's response to things. And for example, if they're a bit unresponsive to any speech or anything, it's really important that they bring the baby back to their GP as soon as possible. And potentially the baby might have to be referred to a specialist in an audiology clinic.
Hi, so I'm Lucy. I'm also a medical student, and I'm the next part of the medicine team talking about the genetics of hearing loss. So as you can see on the screen, genetics are responsible for approximately 50 to 60% of cases of childhood hearing loss. This is a statistic provided by the CDC, so it's American. I couldn't find any specific for the UK, except for the fact that around about 1 in 1,600 children in the UK are born with either moderately or profound hearing loss. A lot of cases of genetic hearing loss are associated with no other symptoms. A lot of them can just be completely isolated. And as Millie said before, it's also really important that some of these diseases or disorders don't come up until quite a bit later. So you can get some children who are born completely deaf. You can get some children who are born kind of mildly or moderately deaf, and over time that progresses. And you can get some children where it might not even present until a fair bit later in life, or, you know, when they're a few months old to when they're a few years old. One of the most kind of identified genes is the GJB2 gene, and that's responsible for development of the cochlea. So mutations in that can quite often be the cause of genetic hearing loss. I've also listed a few different syndromes that have been known to cause hearing loss. So the first one, Alport syndrome, it's a collagen defect. Kind of all around your ears, you have a lot of collagen that helps to stimulate, helps with supporting the growth of the ear, helps with supporting the different structures of the ear. And so you can get symptoms of hearing loss as well as issues with your kidney and eyes. And as with a lot of different types of hearing loss, the high tones are lost first, and then that progresses to the low tones over time. The second is branchiotorrhino syndrome. So that's an autosomal dominant condition, which means if one of your parents has it, then there's a very high chance of the child having it. And that basically causes outgrowths and openings into your ear canal as well as into your mouth. Again, this also affects the kidneys. And as you can imagine, if there's any kind of extra outgrowths that's kind of blocking the ear canal or occluding the ear canal at all, or occluding any of the bones within the ear canal, then also hearing is decreased there. The third one is Norrie disease. This is an incredibly rare disease. From what I've read online, there are only 400 cases of it that have been diagnosed worldwide, kind of ever, really. At least that's from what the statistics that I could find. And Norrie disease is where there is a defect in the Norrin gene, which is responsible for assisting in the growth of blood vessels around your eyes and around your ears. And this is one of the diseases, like we were talking about earlier, where you can get, usually children will have kind of eye symptoms first, and then the hearing loss will come over time. So it can come when the children are 6 months old, and it can either, only mildly reduce, or it can moderately, severely reduce, depending on how severe the disease is.
Hi everyone, I'm Maria. I'm the last part of the medicine team, and I'm just going to quickly run over 3 types of hearing losses. So just to quickly make you aware of a few definitions first. So the first one is etiology, and that's the cause or origin of a disease and the factors which produce or predispose it towards a certain disease or disorder. The second one is pathophysiology, and that's concerning the functional changes that occur within a patient or a victim due to a disease or a condition. And etiology talks about the causative reason, But pathophysiology talks about the pathological changes taking place in a person. And it's really important to be aware about that, because some people tend to confuse them or think that they're the same thing, when in reality they're not. And the three types of hearing losses are sensory neural, and that's damage to the structures in the inner ear or auditory nerve. And the common causes of this is loud noises, age, and genetics. The second one is conductive. So that's when your sound can't pass from your outer ear to your inner ear. And that can be caused by a blockage. So it could be from earwax, it could be from fluid buildup, and it could be from an ear infection. And the third one is mixed. So as the name says, it's a combination of both of the conductive and sensory neural hearing loss. And this can be caused by illnesses, drugs, genetic causes, head trauma, and malformation of the inner ear.
I think Joe's going to be talking about the ENT stuff in a moment, but before we do that, we just did a small slide on actually what the MDT is for a cochlear implant assessment. So in the case of Nina, she's passed a newborn hearing screening, presumably, or she may not have been born in the UK. We see a lot of children in our service that have transferred in. The GP may refer on to a local audiology team that would conduct the hearing assessment. And if they identify a permanent hearing loss, they would then make the necessary onward referrals. So one of them might be to an audio vestibular medicine consultant that would investigate the cause of the hearing loss. The audiologist would organise fitting the hearing aids. A local teacher of the deaf would support the family in the diagnosis of the hearing loss and use of the hearing aids. And there are lots of others, but when they come to the cochlear implant team, they will be seeing a whole range of professionals to complete the assessment. So Joe's going to talk to you now about the ENT role.
Great, thanks, Nasreen. So cochlear implantation, you could call it arguably one of the most remarkable biotechnologies of a generation, in the sense that until we had cochlear implantation, if hearing got to a point where amplifying conventional sound to the max still wasn't enough to give the brain access to speech and language, then the option was to consign that person to the non-hearing world. And so that's where we now have cochlear implantation. So, you know, it sort of was a research within research in the 60s and 70s, and then came into NHS practice sort of late 80s, early 90s. And essentially, as you can see from this diagram, rather than relying on ambient sound to naturally vibrate and stimulate hair cells and induce electrical stimulation to the brain, this electrical device is threaded through into the cochlea, and then we're able to provide direct electrical stimulation of the spiral ganglion of the cochlea. So there's an external part that attaches by a magnet through to the internal receiver stimulator under the skin, and then there's an electrode that's connected to that that is threaded into the cochlea. We could flick on to the next slide. Great. So yeah, as you can see, there's two components: the internal bit, which is receiver stimulator and electrode, and then the external bit, which there's different models that look different, but essentially it will have a microphone and a coil and a processor, so that it can receive sound, digitize it, and transmit it via radio frequency to the internal component. Next slide, please. Great. So who ultimately benefits from cochlear implantation? Well, that is where the MDT comes in. And in a sense, it is one of the greatest examples of an MDT you'll find in the NHS, in that there's lots of different people involved, and we all absolutely need each other's opinion to understand what's going to be best for each given patient. And so when we decide that conventional hearing aids are not enough, then a patient gets assessed by the whole MDT, and then we all come together. But broadly speaking, we're looking for children and adults whose hearing is worse than 80 decibels, at 2 frequencies between 500 hertz and 4 kilohertz. So that's the sort of audiological criteria. And then evidence of poor speech perception as well. And with children, obviously, it's not easy to test speech perception the way we do with adults. And so that's where, again, the MDT is so valuable in having the skills to assess speech, language, listening development in a much more subtle way. And so we've got Steph, who will introduce herself in a second, but she'll be able to share perspectives from a teaching point of view. Right, next slide. Yeah, and you can flick on. Great. So now it's also worth saying at this stage that as a team, we totally respect deaf culture. And, you know, if you've seen films, well, there are loads of films, but Coda being one that comes to mind, there are families that identify as being deaf, that deafness is not a disability and not something that needs corrected or overcoming, and that sign language is as equal a language as any other language. And so it's worth just saying that even though we're in the business of restoring hearing, it's totally appropriate to respect and work with those families. But what's also worth saying is that 9 out of 10 children who are born deaf have parents with normal hearing. And loads of people don't know that. You just imagine, if you can hear, that your children will definitely be able to hear, and deaf children belong to deaf families. But it doesn't work out like that. And so we need to be ready for any type of, to work with any type of family. You'll have parents who can hear and then want their child who's been born deaf to be in the hearing world. You might have deaf parents who want their child to be in the deaf world, but you might also have deaf parents that want their child to be in the hearing world, or both. So we don't make any assumptions, but we do know that if a child is born profoundly deaf, then we've got a limited amount of time to offer cochlear implantation if they are to learn to speak. And if you wait and take time to decide and miss that boat, then even if you do implantation later, the plasticity in the brain has kind of moved on. So ideally, we want to do it before the age of 2. I really ideally want to do it before the age of 1, but definitely not beyond the age of 4 or 5. Otherwise, it'll be too late. So that's really important to understand. The other group is children that were born hearing, learned language, and then lose their hearing later, or adults indeed that had hearing their whole life and then lose it later. That's another group that benefit very well from cochlear implantation. If you're taking an 8-year-old, let's say, that's never learned language and always been deaf, and then thinking about implantation, we might still do it. And often that group come from abroad, because in the UK, they'll have been through newborn hearing screening. But the group that are non-verbal, who are now interested in cochlear implantation, we might still be able to offer it as a way of them perceiving sound. So imagine crossing the road and not missing the car, but we're not going to set the expectation that they'll learn language. Okay, next slide. Great. So I'll just touch on this. So when we recognize that a child is deaf, we also need to think about whether that means there are other things, health things that are relevant. Some of this has already been touched on, but in our team, audiovestibular medicine will lead on this. They'll examine the child from a medical perspective and send off any relevant investigations. Usually that means looking at family audiograms, an ECG to look for syndrome called Jervell-Lang-Nielsen syndrome, which also puts the child at risk of sudden cardiac death. And then, as you can see on that list, ophthalmology, CMV screen, Connexin 26. So there's lots of investigations that come out of identifying that a child is deaf. It doesn't necessarily change their candidacy for cochlear implantation, but it helps us to make sure that a child's, all the child's medical needs are being met and all the right people are involved. So you can see there that actually, although we're talking, more specifically about the hearing MDT, the number of medics involved and another number of allied health professionals involved in this, in a child like this, can be loads. And we've got on here MRI and CT. I'll come on to that in a second. Next slide, please. Thanks a lot. Okay. So again, we've sort of touched on this already, causes of hearing loss. But if you're ever asked in a Viva, what are the causes of congenital hearing loss? Well, the best way to break it down is into genetic and environmental. And within genetic, you've got syndromic and non-syndromic. And then if you're beyond that, then you're probably ready to do your FRCS, but then it's autosomal recessive, dominant, and X-linked for each of those. And then within environmental, you've got intrauterine infections, maternal factors like alcohol and smoking. X-prem is the big one, actually. Children that are born prematurely have a higher chance of being deaf, and then genetic. And there's a big cohort that where the cause is unknown. So there's loads of babies that we treat where we never find out what's caused their hearing loss, and we just move on and deal with it. So yeah, so it's helpful to understand, but it doesn't change necessarily at the moment what we do in terms of the hearing. Okay, so if a child's been considered for cochlear implantation, we'll do an MRI scan, and that's for a number of reasons. We want to see that the cochlea on each side is patent, and that's important because if they've got cochlear anomalies, then that might make putting in an electrode harder. You want to see that the cochlea has space to put an electrode in. So if they've had meningitis or trauma, hopefully not, but then there's a chance that the bone within the cochlea can become scarred up and stop me from physically threading that electrode in. And it's nice to know that ahead of time. And also you want to see the integrity of the vestibulocochlear nerve, which, as you of course know, is the 8th cranial nerve. And that needs to be intact in order to deliver the electrical stimulus from the cochlea to the brainstem. So those are all the things we're looking for. In adults, we also do a CT scan, but in babies, we often make the decision not to do a CT scan on the basis of the radiation involved doesn't necessarily bring that much benefit. But certainly if I'm worried about surgical hazards, then we might do a CT scan as well. Next slide, please. Great. Yeah, so as I was saying, the CT acts as a nice roadmap for me and does give some extra information, but with the babies, we tend not to. But that does vary from centre to centre. And there are 20 cochlear implant centres in the UK and Ireland. So you'll all have a local regional centre. All right. So yeah, as I said, identifying those abnormalities helps to establish whether cochlear implantation is going to be feasible and a good idea. So we want to see a cochlea and a vestibulocochlear nerve, and it might also influence the type of electrode that we go into. I'm not going to go into too much detail because it is quite a niche and advanced thing, but needless to say, there are different types of electrode that we can use for each given condition. Great. So the surgery itself, it's come a long way since the 80s when it first came about. It's now a day case. I can generally do each ear in about 60 to 90 minutes or less, which means that a bilateral cochlear implant in a baby is done in a morning list, and they can even go home the same day. It's not often too painful, but paracetamol and ibuprofen usually afterwards is useful. They'll have that sort of Princess Leia-like head bandage that you see there, which comes off the next day. And we usually counsel parents about the benefits of a meningitis vaccine before surgery to reduce the already quite low risk of meningitis. But we are, operating quite near the base of the brain, and we're opening the inner ear, we're opening up the cochlea. So we do want to keep that risk low. Most babies will have meningitis vaccine age 1. So when we're doing the 6-month, 7-month-old babies, then we have a discussion with parents around, if they're too young to have the vaccine, then we'll usually cover them with extra antibiotics afterwards to mitigate that risk. Then we usually review them at a week, check the wounds are all healthy, do an X-ray for the babies or a CT scan for the adults, and then let everything settle down. And then the real fun starts after about 4 to 6 weeks. So there were 4 manufacturers. There are now 3. Without going into too much detail, one of them has stopped, but The other three have been going a very long time: Cochlear, Medel, and Advanced Bionics, ever since cochlear implantation came to market. And within each manufacturer, there are different electrodes that we might choose for different reasons. But I'll leave it at that level of detail. With Medel, we can also adjust the length of the electrode to sort of map the length of the cochlear duct as well. So, and this is a field that's just getting more and more. There's always advancement. So it's a really, if you love tech and medicine, it's kind of the ideal field to work in, really, because there's always something new on the horizon. Okay, I'm sure no one is squeamish, but if you are, then, well, it's too late. So this is a very sped up video of me doing a cochlear implant on a baby. After opening the skin, you can see I'm drilling a tunnel between the ear canal, the base of the brain, what we call the tegmen, and then the line that joins that triangle up, which is where the sigmoid sinus will be, which is the largest vein that drains the brain. So that video stopped. There's more to it than that, actually. I don't know if it's, oh yeah, there we go. Yeah. So, and then I tunnel away gently, carefully, and then eventually in the distance, I find the incus, which is the second ossicle. And that gives me where that drill was there. And then that gives me a line to drill that hole that I'm drilling there, called the posterior tympanotomy. That's a 2 millimeter gap between the facial nerve and the chorda tympani, the taste nerve. You can't get that wrong. That's probably the hardest bit of the operation. And the facial nerve monitor does sometimes beep at you when you're very close to it. And then that then opens up for me to access the round window of the cochlea. And then, as you can see, I've then threaded in the electrode. And then the rest of the internal bit sits under the temporalis muscle, under the scalp. So that's cochlear implant surgery. I skipped the sewing up the skin bit because you've probably all seen that. No, that's fine. That's fine. You can move on to the next slide. That's great. So post-op scans. So in the babies, we generally can't realistically do a cone beam CT scan. So we do an X-ray, as you'll see on the left-hand side. We just want to see that the X-ray is curled up. The electrode is curled nicely into the cochlea, which it is. That kind of gives us some surety that it's in the right place. And then it will also guide my audiology colleagues at switch on to know, if one electrode is not quite in the cochlea, then they can get around that by switching that electrode off, etc. Good. Now, parents often want to know about complications, and it's, from a parent's point of view, it must be. We know that it's frightening giving your child over for any sort of surgery, particularly something like this, which is such a life direction changing thing at such a young age. Thankfully, the risks of surgery are not very common, and they're all very manageable, but we always have to counsel people appropriately. This slide about balance is really more relevant for the adults, but you are putting an electrical device into the cochlear vestibular system, so you can end up irritating the balance system and putting people off balance, although we hardly ever see kids have issues with balance, really. Only very rarely if they've got other issues with other faculties, such as their eyes or their feet and joints. Next slide. And then obviously it's an electrical device, so it can fail at any point. We hope not, but a bit like your fridge, when you buy it, you hope that it will last forever. In theory, these can fail at any point. Most of them do really well, and some of the implants that were put in when cochlear implantation first started are still going today. But it's fair to say that there have been implants that have failed and needed replacing. So that's something we always counsel people around. And then obviously infections. An infection around an implant is bad news. So we tend to get on top of infections early with antibiotics. But if pus breaks through the skin, then really the only way of settling down that infection is by taking the implant out, unfortunately. And once or twice a year, I'm faced with that very difficult scenario where I have to do that. And we usually try and leave the electrode in so that the cochlea is still patent when we come to put the reimplant in 3 to 6 months' time. Okay, next slide. Yeah, and obviously the other complications are related to anatomy. So as you could see in that other video, I'm placing the drill pretty much on the facial nerve and on the chorda tympani, which supplies taste to the anterior 2/3 of the tongue. So obviously counsel every patient around the risks to that, although facial palsy after cochlear implantation is thankfully vanishingly rare, and we use a nerve monitor. We can end up, the natural hearing, as you can imagine, if some patients might still have some natural hearing left, even though they're opting for cochlear implantation. So we always warn that that might be lost after surgery, although it can be preserved sometimes. And then the other things are very minor. So CSF leak, scarring, numbness around the top of the ear, and then device related issues like the electrode falling out over time, or causing pain when you turn it up, when you turn up the gain. Next slide. Great. And just a note to say that obviously I'm here telling you all this today, but we're very much grateful for the pioneers that discovered and made this happen, really, because it is still kind of mind-blowing in 2022 that we can stick an electrical thread into someone's cochlea and somehow they can hear it detailed enough to follow speech and language. I mean, still sort of something out of a sci-fi film, really, but we are doing this. And as you can see from those pictures, the tech just gets better and better with time, gets smaller and sleeker. And actually our unit was the first to, well, one of the first to be able to offer cochlear nucleus 8 in 2022. So then, you know, they're always trying to innovate, which is great. So there'll always be things on the horizon. So yeah, I'll stop there. What's the next slide? Yeah, I'm done.
Hi, I'm Freya. I'm a second-year children's nurse. In this scenario, there are a number of different roles that the nurse could take. If you are a clinical nurse specialist specialising in hearing and hearing loss, you may help to facilitate the assessments with the audiologist and the ENT surgeons, as well as being a regular sort of point of contact for the family throughout the pre-op process, the assessment process, and the post-op process. As well as this, you'll have theatre nurses and scrub nurses, which will be actually present during the surgery. And as well as this, you'll have pre-op and post-op nurses. So it's kind of like a conveyor belt in theatre, where you come in, you go into the waiting room, and you've got the interviewing nurses, and then you've got the nurses that will do your pre-op assessments. When you go to theatre, you'll have the nurses that are actually present in the theatre, and then you'll have the post-op nurses who will help with extubation, monitoring post-op vitals, giving any post-op medications, and planning for discharge, and supporting the family, giving them the correct sort of information, and supporting the doctors and the other specialists, sort of coordinating the care between the different professionals. In addition to this, you may be taking part in assessing the wound healing, checking for any signs of infection, making sure everything's sort of healing as it should be, and liaising with the health visitors or school nurses, depending on the age of the young person. And being the voice for the patient and their family, and then liaising and possibly attending follow-up assessments as well with the appropriate professionals. And I'll pass on to the next slide.
Back to me. I'm sorry I didn't introduce myself earlier, but thankfully Joe wrote in the chat for me. But in case you missed it, I'm Nazreen. I'm one of the audiologists, so I work with Joe and Steph with UCLH. So if we go back to the MDT pathway, so with Nina, she's had her assessment, well, she's having her assessment with the different professionals, and I'm going to talk to you about how audiology fit in that pathway. So we would be part of the assessment, and then the professionals all meet together in an MDT meeting, and the outcome of that meeting is relayed to the family at an appointment. If with Nina we offered bilateral cochlear implantation and the family accepted, they would then come for an appointment with audiology to choose the device. So to choose which manufacturer they want to go with, which Joe mentioned earlier. Then following the surgery, they would come to see audiology for their switch-on appointments. So this usually happens about a month after surgery. And we normally have about 4 appointments in total for children, which are usually about a week apart. Go into the next slide, please. So with audiology, usually if the child is, I'd say roughly below the age of 7 or 8, it's normally always 2 audiologists seeing the child. And the reason being is practicality with the kind of assessments and testing we do. So Nina's 9 months old, and providing she has normal motor development, where she's able to sit with no support or minimal support at the waist and has good head control, the behavioural hearing assessment we would do is something called visual reinforcement audiometry. So VRA involves one audiologist sat in front of the child and the other sat behind presenting the sound. The sound might initially be presented via a speaker like the one shown in the picture here, but eventually we would want to present it via headphones to get separate ear information. So at the beginning, we play the sound at the same time as a visual reward. So in the picture here, it's a video on a screen. Sometimes we use puppets, or we might use flashing lights, especially where the child might have a visual impairment as well. And then eventually you play the sound on its own and see if the child can turn to the sound and know that they'll get a visual reward at the same time. And then if they are able to do that, the sound is turned down and we plot their minimal response level on an audiogram. So if we look at the next slide, there's just some examples of audiograms. Joe showed you some earlier, but this just shows different kinds of hearing loss. So the blue crosses are the left ear, red circles are the right ear. So on this side, you've got a severe to profound hearing loss in both ears. And on the audiogram on the right, you've got normal hearing in the low frequencies, steeply sloping to a profound hearing loss in the high frequencies. So Nina could have either, and both are within criteria in terms of audiology for bilateral cochlear implantation. On the next slide, apart from behavioural hearing assessment, we do have lots of objective tests that we can do as well. So tympanometry looks at middle ear function. So sometimes there is additional conductive component on top of the sensory neural hearing loss. Millie earlier spoke about the OAE and ABR testing in the newborn hearing screening. So in audiology, we do the full diagnostic test version. ABR can take 90 minutes or more, sometimes in babies, and when you're doing multiple frequencies and, well, if you're waiting for a baby to sleep as well. Nina most likely would come to us with hearing aids fitted already, but part of the assessment is actually assessing, do those hearing aids give her sufficient access to develop speech? And that in turn can support our recommendation for cochlear implantation. And the next slide, I'm going to just briefly talk about what audiology do in a switch-on appointment. So as Joe says, we would look at the radiology reports on the post-op X-ray or scan. So you can see on the image at the bottom there, there's different channels on the electrode. And if any of them are lying outside the cochlea, we would turn them off. Via the programming software, we can check the function of each channel and again decide if any of them need to be turned off. At switch on 1, the sound is quite low. So some adults will say it sounds just like beeps at the beginning, or some older children and teenagers will say we sound like Mickey Mouse or Daffy Duck, or it sounds very robotic. And it slowly, the sound gets turned up at each appointment and generally becomes clearer. The aim by the end of switch on is to have a stable level of sound, and we repeat the behavioural hearing assessment with the cochlear implants on, with sound presented via a speaker, and each manufacturer has a recommended level of what we should get for aided detection. So you can see on the audiogram at the top of the slide, you've got red for right, blue for left. That child's hearing everything between 25 and 30, which for a device by Cochlear is what we would recommend. And then following switch on audiology, we'll see a child all the way up until they're 18 and transfer to adults at least annually after the first 2 years post switch on. So that's it for audiology.
Can everyone hear me? I'm just a bit worried that no one can hear me, but I think it's okay. I'm Abby. I'm a third year speech and language therapy student. I'm going to start my section by giving some information about the link between early hearing loss and language acquisition. So I've got 3 points, and I just wondered if maybe you might want to pop something in the chat box about why the things that I'm about to read out might be something that a speech and language therapist would be concerned about. I'll try and keep an eye on the chat box. So the first one is, babies begin to hear in the first trimester. So what might this mean for babies if they can't hear during their time in the mother's womb? The second one is sounds such as a mother's intonation pattern is readily available. And because of this, this can, when they are born, result in a lack of attachment to their mother or their caregivers. So maybe have a think about how that might affect development of language later on. And the last one is animal studies have shown that when babies are deprived of their hearing, their neural structures don't develop the same way that a typical baby's would. I'm just gonna have a look at the chat box to see if anyone's got any ideas. Nothing at the moment. Maybe I'll just answer for everyone. Yep, correct. Yeah. Yeah, it can really get in the way of social development, and the way that children will go forward and form attachments, you know, how they might do at school. Yeah, knock-on effects for social relationships. Yeah, missing milestones is something that we commonly see with infants or children with a language, with a hearing loss. Sorry. Yeah. So the problem with not being able to hear when you're in the room is typical children will be able to have an early speech perception and a range of auditory experiences even before they're born. Yeah. And because of their experiences before birth, when they're in the womb, babies prefer familiar voices when they're born. So they prefer speech sounds compared to other environmental sounds. So that just shows the preference and actually how much babies do absorb still when they're in the womb. So infants are commonly referred to us when their hearing loss is affecting their development of their communication. So common problems that we tend to see are infants or children not turning towards someone saying their name or trying to catch their attention. They're not being startled by loud sounds. And most of our intervention for this particular case would be about facilitating speech and language development and providing early intervention so that we can sort of prevent some of the difficulties that they may face when they become an older infant or a child. So these will include difficulties such as having difficulties hearing higher frequency sounds, such as maybe or because they're quite high frequency. So this can include saying it, so finding the right place in the mouth to articulate those sounds, or being able to hear them and understand them in other people. Slightly older children as well, we'll see them if they're having difficulty with their speech, so if it sounds distorted, and we'll help them make their sounds clearer and more intelligible. However, this is a 9-month-old, sorry, 9, wow, just got to beat there, a 9 month child. So much of our involvement in this case will be counselling the caregivers and being involved with the MDT decisions about the best recommendation for hearing technology for the infant, and also facilitating and improving the infant and caregiver interactions to facilitate language acquisition. So in our patient's case, we might begin by meeting the mother, the infant, the caregivers, observing their interactions, and then having discussions on what the caregiver might be able to do to improve or add to the interactions in order to encourage better understanding and acquisition. So, for example, we might recommend that the parent uses more physical touch with the infant to keep them engaged, or if we're observing an interaction to do with a toy and they're playing, asking the parent to avoid looking downwards, so that the infant, instead, when their head is upwards, they can maintain eye contact, they can get used to lip reading. We might encourage different alternative and augmentative communication strategies, such as sign language and Makaton. And we also might encourage parents starting to use PECS. PECS is a communication system. It can be done very high tech on iPads, but it can also be done quite low tech. So using just pictures. So some children will have like a lanyard, and they'll have laminated pictures that will have things like play or food, etc. So that their communication is ready available when they're speaking to someone. It will also be our job to advocate for the child for the best course of action given their degree of hearing loss and the effect that might have on their language and their communication. So we will make cases at MDT meetings about eligibility for further assessment or technological support as a government granted iPad technology or hearing aids or a cochlear implant. I know that was a bit of a whistle-stop tour, but I was quite conscious that I was going to go over, but I've gone quite quickly. So if anyone has any questions, please do pop them in the chat box or ask for my email or anything like that. Thank you.
Hi, so I think it's over to me now. As I said before, I'm Steph Holder. I head up the Specialist Teacher of the Deaf team at the Royal National ENT Hospital, working with Nazreen and Joe. So I'm just going to think about Nina for a little bit longer and think about the role of the teacher of the deaf in cochlear implant assessment. But actually, if we're thinking about Nina being a 9-month-old baby, then in our hospital, the assessment will be collaborative in one appointment with the teacher of the deaf, speech and language therapist, and clinical psychologist. For small babies, they're having a lot of interruption into their early life with their family anyway, coming to the hospital for all these appointments. So we try as much as possible to reduce the number of visits that they need to make to the hospital and try and get as much information as we possibly can. So in the case of Nina, she would come to our baby clinic, and that would be the 3 professionals there together. And then in terms of what we're looking at, we're really wanting to see, does the information we see in terms of their behavioural responses to sound match with what Nazreen and her colleagues would get in terms of their audiological testing? We want to see how much those hearing aids are giving access to the speech frequencies and at what level we see those responses. So we present sounds in a range of ways, from musical instruments to voice. We might use what we call the Ling 6 sound test, which is 6 sounds that cover all of the frequencies in speech. And we're just looking to see if the child is going to be responding to those sounds. She's a 9-month-old, so we're only going to be looking for certain responses, such as looking up or showing detection. She's not going to be repeating those sounds, obviously, but for children who are older, we would be looking to see if they're able to repeat those sounds. We also look at their play skills. This gives us an idea of where they're at in terms of their language development, because language comes in many forms, as we've discovered today, as does communication. And we also want to look at their social interaction. Do they maintain eye contact for a duration of a vocal turn or a communicative turn? This gives us an indication if there might be some other things going on for a little baby, or if we're seeing typical patterns of development. For older children, we would do a very detailed assessment of their speech perception skills as well as their language, which would come from the speech and language therapist. And we have a whole battery of assessments that we would carry out. Often we're not able to do these for older children in one appointment, even though the appointment is an hour and a half, because there is a lot for us to find out. So it's all very much dependent on the developmental stage of the child. But what we're really looking at is what the hearing aids are doing for them. Are they giving them enough? Are we seeing typical patterns of development, even though there may be some delay in terms of their hearing and communication because of the result of their deafness? And a huge part of what we do is counsel families with regards to expectations, what the process is, what to expect should their child be offered implants, helping them to think through what the possible scenarios might be. We always say to them, we don't have a crystal ball, we can't see into the future, but we do this very thorough assessment to give us an indication of what they might expect in terms of their outcomes. Following implantation, as Nazreen and Joe have said, Joe said all the fun begins. The fun certainly does begin for us in our Todd and Salt roles, because we do a whole lot of play and listening activities and interaction to help them maximise the output that they can get from their implants. So Joe will put them in, Nazreen will program them, and then we'll help the child to make use of them and support families with the sorts of activities they can do to help them progress. Our ongoing assessment and monitoring goes throughout the first 10 years following implantation, and then we do one more appointment with them just before they transition to the adult service as well. So we can have families known to us for many, many years. There's lots of other things that happen too, but we haven't got time to cover that tonight. I'd be here all evening if you let me. So if we could go on to the next slide, please. I thought I'd just share a few facts with you. You may know these already, and Joe has already touched on a couple. But this is taken from the CRIDE report 2021. This happens every year. CRIDE is the Consortium for Research in Deaf Education. So you can see that there are at least 45,060 deaf children in England. I've taken the England report. Apologies if this is a UK-wide venture. You can see if the places in which deaf children and young people might be educated. So it might be a surprise to you to know that 78% are educated in mainstream settings, only 2% in special schools for deaf children and young people. So it just shows that the highly specialist level of input that they can have. Also, Joe mentioned earlier, 90% of deaf children are born to hearing parents, and thinking about what that means for those families. Perhaps they have some experience of deafness from older relatives, but helping them to understand what that might mean for their child, us learning what their hopes are for their child, and then helping to try and match the two together. Only 9% of deaf children have cochlear implants. We work with them every day, so it seems like a lot more, but in terms of the deaf population, it's 9%, and you can see the different levels of deafness there. I think, as Joe said at the start, MDT working is absolutely crucial, and I think in the field of deafness, this is where we have had for a very, very long time, many years, the ideal collaborative working in terms of education and health together. Because as soon as a child is identified as deaf, the audiologist or the audiovestibular physician will refer, with the family consent, will refer that family to the local specialist service of teachers of the deaf, and they need to do that within 24 hours. And then the teacher of the deaf, who works in the education environment, so in homes and schools, has 48 hours to make contact with that family for a baby who's identified as deaf following newborn hearing screen. If they're picked up later on, then the teacher of the deaf has 5 days to get in touch. That's the quality standard, and that's what we aim for. So as you can imagine, there are people coming into this family's life after their baby is just a few weeks old. So we have to be very mindful and very careful about how we work with families. If you wouldn't mind moving on, please. So I just wanted, Joe and Nazreen asked me to talk a little bit about the British Association of Teachers of the Deaf, but I thought I want to just share with you a little bit more about what a teacher of the deaf is. I've put extra information on this slide so you can go away with it, but I guess the main points that I want to make are that it is every deaf child's right to have specialist input from a teacher of the deaf. So we are teachers first, qualified teachers working in schools, who then have an additional training and qualification to work with children who are deaf. There's only 3 areas in terms of special educational needs and disability where there is a requirement, a mandatory requirement for extra qualification, and that's to teach children who are deaf, blind, or with multisensory impairment. And I think the reason why it's recognised that they need this extra input is because their needs are really complex, and children with sensory difficulties, as in hearing, vision, or a combination of the two, they are described as low incidence, high need. That means the numbers are incredibly low when you're thinking about the typical population, but they require a highly specialist level of input to guide them through on their education journey so that they're able to fulfill their potential and achieve their hopes and ambitions. So it just says on there just some of the things that a teacher of the deaf might be doing. In fact, probably would be doing. We'll move on. We don't want to run over time. We all need to have dinner at 8. So again, this just shows how we work to ensure the best outcomes for deaf children and young people. At the key of our working is family-centred practice, absolutely crucial. It's not our choices that we make for the children, it's the parents' choices and the young person's choices. It's up to us to give them that information so that they can make an informed decision about what they want for their child or what that young person wants for their future. And as I said before, partnership working is absolutely crucial, and it is well established in terms of partnership working with health and social care and third sector organisations. Next slide, please. Oh, that's a bit random. Do you mind clicking through? Very random. I did not check for animations. Okay, so this is just a plea. Any of you working in general practice or you know, where you may come across a child who is deaf, as I said before, it's a quality standard that they receive intervention as soon as possible. Joe talked about the brain plasticity and the importance of early intervention. That would be for anything, whether it's language input through sign, whether it's access to sound through hearing aids, or the hearing aids aren't doing enough and we want to consider cochlear implantation as an option to give them the best access to sound. But early input is crucial. It's an open referral system, so if you come across a deaf young person in your care, there is almost certainly a teacher of the deaf involved, so it is worth you asking the question just to find out. In order for us to work safely with children and families, we need to be aware of everybody who's involved and not work in isolation. So again, I can't stress more the need for multidisciplinary working. Okay, thank you. Next slide. So in terms of the British Association of Teachers of Deaf Children and Young People, we are the sole professional association for teachers of the deaf. We are UK-wide. We have multiple partners that we work with. This image here is a hyperlink. It will take you to the website. But our key partners are obviously government, voluntary bodies, the Royal College of Speech and Language Therapists, National Deaf Children's Society, British Association of Audiologists, you know, all of our allied professionals that we would be working with. It's really important that we work together to help to develop policy and practice. And last slide, please. Just one thing I wanted to highlight to you. Oh, I'm sorry, I want to make one more point. It just popped out of my head and popped back in again. Please remember, if you come across a child and their speech isn't developing as you would expect, what do you think is the first thing to get checked? Do we want to refer to a speech and language therapist, or do we want to do something else? Any comments in the chat? Thank you. Hearing, yay, that's why we're here. Before anything else, if a child's speech isn't developing, we want to make sure that they can hear it first of all, just to make sure that that isn't the reason why their speech isn't developing. So please, 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 if you ever come across a child, make sure their hearing's been checked. And sorry, my last plea. One of the most recent pieces of work that Battled has done amongst many, but this is something that we have just recently shared out with all of our partners. It's about the language that we use when we're working with families when their baby has been identified as deaf. We always used to use the phrase diagnosed, but diagnosed can have a negative connotation. So we try to use the terminology identified. Their deafness has been identified. And we try to say deafness over hearing loss as well, because if they're congenitally deaf, they didn't have hearing to lose in the first place. They never had it. We could describe hearing loss for somebody who may have progressive deafness or sudden onset, but we just try to be really mindful of the language that we use. And also, you may or may not be aware that there are quite negative connotations around using the word hearing impaired. Impaired makes it seem like there's something wrong. And as Joe clearly said at the start, it's not about there being something wrong and something to be fixed. It's about giving an aid through amplification, if that's the hopes from a parent for their child or for the young person themselves. But we try to use the words deaf, hard of hearing, partially hearing. So that was just a small plea from the teacher of the deaf profession for allied professionals out there. And I think that's it from me. Thank you.
Great. I see my books up there, so that's probably me, but that's just a cheap advert for, well, if any of you medics are going into ENT, then the book on the left is kind of quite good for med students and SHO level. And then the one on the right is for useful further down the line. So do you have, and the one in the middle, it's quite expensive, so get your library to buy it. And then, yeah, so I guess Tash and Nikki sort of met me through this Instagram channel. I set it up, well, I don't really know what I was thinking when I set it up, but I guess it was an opportunity to maybe make what we do a bit more visible and accessible. And I guess, you know, I've been a consultant, well, for 4 years now, but, you know, not long ago, I was in your shoes as a student. And it's important for you all to realize that all the roles that you've seen today, they're all very accessible. They're all going to be filled in the future by you guys. And it's very easy to kind of think, you know, feel imposter syndrome or feel like, you know, it's just how will I ever reach that level of knowledge, but you will. And so, yeah, just an encouragement that you can do it. And you'll see, you know, on Instagram that, you know, it's normal people that do these jobs ultimately. And yeah, so I try and in my spare time fill it with kind of useful educational bits and insights into the working day. And I've got lots of ideas for more things that I'm going to put on there, but having a young baby at home has stunted those efforts, but I will get back on it pretty soon. So do give it a follow if that's of interest to you. Great.
Great, thank you all so much. Thank you so much. Firstly, I hope you guys can all join me in giving a massive thank you to all of today's speakers, especially Joe, Nazreen and Steph, our guest speakers, expert speakers from UCLH that have come to speak to us this evening. I hope you found their input as invaluable as I have. If you do have any questions, please feel free to put them in the chat. And just a few things from us now. Millie will be putting the link in the chat to the medal, which is where you can give us your feedback. And upon completion of that, you'll automatically get your certificate for having attended today for your records. Like we said, we are a free organisation. Everything we do is free, always has been, always will be. But if you do have a couple pounds spare and wish to donate to help keep us up and running, so that covers things like keeping our website going, having our Zoom subscription, then if you are interested, we'd be really grateful for any donations. You can scan the QR code on the right for that. That being said, thank you all so much for tuning in this evening. I hope you guys have enjoyed it. Be sure to follow us on social media if you aren't already, so you can stay up to date with all our upcoming webinars, blog posts, articles, social media campaigns. And this recording, along with all our other MDT webinars, are uploaded onto our YouTube channel. So if you want to go explore the MDT further, which I encourage you all to do, then that's a really good starting point for you. So that being said, we'll keep the Zoom running running for a couple of minutes, you can scan the QR code. And yeah, thank you all so much for coming, and enjoy the rest of your evening.